Hello, everyone. Time to get back to work. It's my pleasure this afternoon to introduce Dr. Catherine de Fontenay as our second keynote speaker at the conference. Catherine was my colleague here at UNSW a few years ago. She has had a successful academic career, including at the University of Melbourne, and a few years back decided to contribute to society in a different way and has been a commissioner at Australia's Productivity Commission, where she's been doing some great work, including the work she's going to talk on today, which is about measuring health and health productivity. So without further ado, Catherine.
Thank you very much. This is a very intimidating audience to be talking about productivity in front of. David suggested that I start by explaining what the Productivity Commission is, since for those of you that are not from Australia, that might not be a familiar concept. So yes, the Productivity Commission, our motto is, it's not as boring as it sounds. Like the BEA, we have our origins in trade policy. So we started as the Tariff Board in 1921, and then we became the Industry Commission. Gradually over time, we became it became a force in favor of free trade, a force in favor of pro-efficiency reform. So initially, firms had to come and explain why they needed a very high tariff rate, and the arguments that we accepted became more and more stringent. So we have a great interest in productivity. We're essentially a little bit of a think tank for the government on what types of productivity reform would be helpful. But that means that productivity statistics are really important to us in our work. And so the challenges in measuring non-market productivity are definitely important to us. That said, we are not a statistical agency, so we have a lot to learn in this area. I'm sure you will all tell me just how much, but you should think of this as a first foray into this area in the Australian space. But I do want to say some huge thanks in particular to the Bureau of Economic Analysis. A number of people spent a huge amount of time giving us detailed feedback on this work. And really, their work in this space is kind of the gold standard. It's very unusual to have a statistical agency whose economists publish in Econometrica on these types of subjects. So they really are kind of a privilege to learn from. We also had help from David Cutler, Kevin Fox, John Goss, Ralph Lattimore. The Australian Institute of Health and Welfare were kind enough to give us data and also a lot of advice on this project. And I particularly want to shout out to Jason Annabelle and the team at the Australian Bureau of Statistics, who were the first to try and tackle measuring productivity in this area. Unfortunately, for budget reasons, it hasn't been able to be a major focus in the last few years, but this is really trying to build on their work. So many thank yous. So why are we interested in non-market productivity? So productivity is in the news a lot in Australia this year. This is a bit of a surprise to us. Normally, nobody wants to talk to us at parties, but all of a sudden, everybody wants to discuss productivity. And it has come to people's attention that real wages are stagnant, and that's because productivity is stagnant. We're essentially round about the level that we were on average between the 2015-2019 period. So this is labor productivity, and so it's not looking good. And what you can see from this picture is that over all of this period, but particularly recently, the non-market sector has been a huge drag on productivity. In part because the ways that we traditionally build it, the ways we traditionally measure it, it's zero by construction in a lot of parts of the non-market sector. In parts of the non-market sector where there's been some capital shallowing, such as the expansion of the NDIS, it can even be negative. But whether it's zero or whether it's negative, it's bringing down average productivity in the economy. So if we're stressed about productivity, people are very stressed about non-market productivity. So the question is, well, we know that there's some challenges with the way we measure that. If we try and measure it in different ways, is our concern warranted? Should we be worried about productivity in the non-market sector, or should we not be worried? And diving into health in particular, healthcare spending has been growing quite fast in Australia. It's been growing faster than real GDP. And at the same time, it looks like we may have been getting really good bang for our buck. So lifespans have been increasing at a rate of knots. It's gotten seriously challenging to plan for retirement in Australia because you might be living an extra decade, who knows? And so the question is this attributable to what we're doing in healthcare, or is this attributable to other factors such as not smoking campaigns or other changes? And so are we getting value for money in the health sector? We've got increased spending on health, and that could be because of what we call Baumel's cost disease. So Baumel's cost disease is a really depressing thing that we at the PC worry about all the time, which is that if you have a sector like manufacturing that gets more efficient, you spend less money on it. And that means that you're spending a bigger and bigger share of your income on less productive sectors. And so Baumel's cost disease is that those unproductive parts of the economy are gradually going to take a bigger share of employment and GDP. But in terms of health, if we look at that life expectancy, we could be spending more money on it just because we're getting great bang for our buck. We're happy to spend for more life expectancy, and that's what we're getting. So which of those is it? We'd really kind of like to know. And yeah, anyway, you get the idea. We're worried about the non-market sector. It's all bad. It's growing, it's big, should it be growing? Is it productive? We don't know. So what are these challenges in measuring non-market sector productivity? I should say now that I'm talking from now on about multi-factor productivity. So the productivity of the value added that we're creating relative to the cost of our inputs. So what is the challenge? Well, the challenge is that normally when we measure productivity in the market sector, we use prices. We use the prices of the goods that are sold, and we use them as a measure of the marginal value that consumers are getting from those goods. And so that tells us about their productivity. If you buy something that's worth $20 and I buy something that's worth $10, the thing that you're buying is delivering at the margin double the productivity, double the value added to the economy. But that's just not necessarily true in the non-market sector. That's how we define the non-market sector, is that the prices are not real prices. So we have some non-market services such as schools or hospital care that are either free or heavily subsidized. And so that price is not going to reflect the value of that service. And then even in the parts of the market that are for profit, because there is either large government subsidies in these markets or government regulation, there's a number of ways in which the price is still not reflecting the true marginal value of the service. So if I use a private hospital, I'm thinking about the fact that I could use the public hospital for free. If I attend a doctor's office, I'm receiving a subsidy from the government. So the prices are not real prices in the way that the market sector has prices. Sorry, I know most of you know this, but just we like to remind ourselves of the building blocks. So what is the normal way that we measure output and from there productivity in the non-market sector? Well, in a large share of it, we measure it in terms of costs. We look at the share of output that we produce we look at the outputs that we're producing in period t+1. We compare them to the outputs we're producing in period t, and instead of prices, we're using cost, because that's our best guess. We're sort of, what we're assuming is if the government's choosing to provide it, it's because the value of this is roughly, the cost of providing it lines up with the value someone's getting, and therefore cost is kind of a good proxy for the value of that service. Brain surgery, more expensive because it's very valuable, if you will. But there are some real challenges when we start thinking about applying this to something like healthcare. The first is that if there are improvements in the quality of the service, that doesn't appear in this formula at all, right? So if I have better outcomes in terms of my quality of life or my survival from a medical treatment, that's not in this formula at all. That's the first problem. The second problem is that our categories, our little I here in the formula, every different activity is a category. So a hospital visit for chemotherapy is an activity. A hospital visit for dialysis is an activity. If I find a way to shift that activity to another setting, and over the last couple of decades in Australia, we've been very successful at reducing the cost of some treatment by moving it from hospitals to general practice into your GPs. If I do move a service from the hospital to the GP, that's a different activity, okay? And so your measure of productivity could go up or down because you've reduced your number of high-cost activities. You've moved it to a low-cost activity. It doesn't follow that productivity is going to improve. So both of those measurement challenges are ones that we wanted to, are ones that other people have addressed in research overseas, and they're some of the ones we wanted to tackle for Australia. And so using this type of measure of output and then comparing it to measure of inputs, we found the ABS was able to measure multi-factor productivity for hospitals using these traditional methods, which they emphasize, and they found that hospital multi-factor productivity grew by 0.1% per year over the period that we're looking at. And over that period at least, productivity was a little less anemic in the market sector. It was 0.7% per year. But you can see how with this structure that we were just looking at, it's very hard to get a measured productivity improvement. Essentially, you have to deliver the exact same thing, but for less. Other ways to improve productivity, changing where you do changing to a low-cost setting, or delivering better quality outcomes, those aren't in our measure. Okay, so a lot of amazing work has been done in this space, and so I just want to give us a little bit of a sense of the options. So initially we were thinking we would just write a really nice literature review because there's a lot of great work out there. So the first question you have is, are you going to measure outcomes? Are you going to measure outputs, or are you going to measure outcomes? So are you going to measure at the level of one hospital visit, for example, or are you going to measure at the level of one treatment for leukemia? So the whole course of treatment if you happen to be diagnosed with leukemia. So the ABS's initial experimental measures in this space were looking at the productivity of a hospital visit and exploring other ways to measure that. The NHS, in terms of the ways they were looking at this in the early 2000s, because there's a lot of good data being gathered on the actual hospital visit, a lot of what they were thinking about in terms of outcomes was, let's look at one hospital visit, and the quality measure will be about the 30-day mortality after your hospital visit, for example. So that's one visit. And then there's the so-called disease-based approach, which is to try and figure out, well, how much did we spend on you during your whole course of the disease? And in the case of this Cutler paper, what outcomes did you get? So the BEA satellite account, they are tracking, they were tracking the expenditure on one case of the disease, if you will. And so they're looking at everything that is spent on one course of the disease. The next decision that you have to make is, are you going to measure outcomes directly, or are you going to measure outcomes indirectly? So indirect sounds negative. It's not. It's a really cool technique as well. So indirect measurement of outcomes is most famously used in the work of Abe Dunn from the BEA and his co-authors. So they're looking at, they've got data on exactly what technique was used in a hospital. Did you use this kind of stent, or did you use this kind of stent? Did you use this, did you provide aspirin, did you not provide aspirin? All of these different details of the technique that was used, and then using the clinical literature that estimates the cost benefit from that particular technique. So if you use this type of stent, the medical literature has shown that this is how much it costs, and this is the outcomes that you get from that particular technique. So that's the indirect. I gather data on what technique you used, and then I use these studies to figure out what the impact of those techniques is. Then the other way to do this is to try and look at the outcomes that patients have when they contract a disease in terms of their quality of life, their life expectancy, and so on. So David Cutler et al. Did this with, for example, Medicare recipients, looking at people who contract a particular disease and then comparing them to the rest of the cohort to see what their outcomes are. Okay, everybody clear on the choices? So we're going to follow the right-hand side here. We're going to be looking at the disease over the whole course of treatment and a direct measure of outcomes, but it's going to be a lot less fancy than David Cutler's work, I hasten to assure you. Okay, so the way to think about our paper is essentially, it's kind of a proof of concept. Is this feasible for Australia? Could we do this? We're not a statistical agency. We're very much hoping that AIHW or the ABS decide to pick this up and run with it, but it's just kind of, is this feasible in Australia? So it's like a satellite account, if you will. So what are we trying to do? We're trying to measure the growth in healthcare productivity for a subset of the healthcare sector between 2011 and 2018. All right, so again, we're taking a disease-based approach. So the idea here is, after contracting this disease, what is the productivity of treatment? How much did treatment cost? What outcomes did you get? What value should we place on those outcomes? So there's two big assumptions in approaching it that way. The first is we're assuming that existing healthcare does not affect the likelihood of getting the disease. You'll see we have pretty crappy estimates of productivity for cardiovascular disease. That's because we've made big improvements in prevention. And so a lot of the productivity of our treatment of cardiovascular disease we're going to miss, because this is just conditional on having a heart attack. What is your treatment outcome? The second assumption, which again is a big one, is that exogenous changes in population health will only affect the likelihood of contracting a disease, not the effectiveness of treatment. So if you smoke, you are more likely to get lung cancer, but conditional on being diagnosed with lung cancer, your survival probabilities are the same as others. So obviously that's not true. And so this is just a simplifying assumption. Yep. That's all part of treatment. So if you die because of a mistake that was made in surgery, that's part of the outcomes of healthcare. Yeah, good question. So far, so good? Okay. And then what data are we going to be using? We have self-reported disease prevalence data from the ABS's national health surveys over this period. And so this means that we can really only identify chronic diseases that you have for a long period of time, because we're asking people at one point in the year, we're picking up everyone who has it at that point in the year. So chronic diseases, and this data includes a fair amount of useful information that we can use to figure out your quality of life when you have the disease. So your self-reported health, your pain, your psychological distress score. Yep. Sorry, long-term diseases, not chronic diseases. I beg your pardon. I'll get to that, but yes, it's going to be at the aggregate level, so you'll see we'll be kind of conflating a number of things. And then the mortality is from the AIHW burden of disease. All right, and we'll have to use some slightly aggregated categories of disease because these two data sets lump people into slightly different buckets. So the three buckets that we are looking at are we're able to look at a subset of cancers that are about 9% of healthcare spending, most cardiovascular diseases, and a number of the blood, endocrine, and kidney diseases. And so there's a few that are left out, some that have to do with conditions around pregnancy, but otherwise these are in terms of the cancers. So those are our three buckets. And so again, I'm just going to give you statistics at that level of aggregation, again, because the lines between these two data sets don't quite line up. Is there a clock in this room? No. No, that's all good. Yep. Okay. So the main thing to notice here in terms of this not being as fancy as the David Cutler approach is that we're taking an aggregate approach here. So we are looking at the total number of people who contract the disease, who die, who recover. We are looking at total annual expenditure on those patients. So the number of people, we work out from the National Health Survey how many people have leukemia this year. We work out how much is being spent on leukemia this year. Those are the two, but at that aggregate level. And basically the reason is we don't have great data in Australia on a number of health services that are outside of hospitals. So we've concentrated on services that are mostly in hospitals. We're still going to try and guess what they spent outside of hospitals, but this is not going to be we're going to struggle in Australia to estimate the productivity of healthcare where a lot of that healthcare happened in your GP office, for example. Because when you visit the GP, unlike in the National Health Service, when you visit the GP, there's no record outside of that GP's proprietary records. There's no record of what the visit was about. And hospital outpatient visits, we don't have good records. Emergency room visits, we don't have good records. Specialist consultations, we can guess what it was you were there for, but we still don't have detailed records. and some pharmaceuticals we might have to guess what condition they are treating. So it is a kind of a big data gap in Australia. And for once, it's not the responsibility of the AVS. Yes, Alicia. Yeah, please go for it. That would be great.
Hold on, Alicia. If we're going to do questions, better get it recorded.
Thank you. So if somebody goes to the GP, but then they get referred because it's really a very serious condition, they will immediately appear in Medicare with a particular item, right? Mm-hmm. So couldn't we think, with the admin data and Medicare data and Department of Health and all that, couldn't we actually trace those people that, although they visit the GP, then ended up in the hospital system under a particular item or disease or whatever?
Yeah,
so.
I think there's definitely a broader range of healthcare where we could use those types of approaches. But I think there's going to be conditions where that's going to be very difficult to work out. So let's say you have a mental health condition. Sometimes you go to the emergency room. Sometimes you visit your GP. Sometimes you're being treated for other things when you're going to the GP, but they're also checking on your mental health. It just gets very, very challenging for some conditions. But I think you're right. We could use some of those types of clues to get a better estimate for a broader range of healthcare than we've done here. Yeah, great question.
Thank you. Yeah, and the PBS also could be very useful because if a person gets put on a particular item for a cancer, then you can infer that this person has cancer or something, right?
That's right. So I do think that there's potential, but it's not the NHS, I guess is all I'm saying. Please ask questions. I'm very nervous. That will help a lot if I can be distracted by answering some questions. Alrighty. So what we did was we took the total expenditure on healthcare and then divided it up into these different buckets of spending on these health conditions versus spending on other things. So how do we allocate it? So we have pretty good data on the hospital side and in some parts of the emergency department side, where the hospital records, the administrative data has a lot of detail about your condition and the treatments you received. So that's the good data. If you were not admitted to hospital, the data is less good. So, and if you just visit the GP, we are also making a little bit of a guess. And so what we do there is we use the survey of GP prescription and referral patterns from a survey run from 2006 to 2010, now sadly out of use. So we're just guessing that the patterns have continued. But essentially, we worked out, in that survey, we had information about exactly what was going on in GP visits, what share was for what condition. So that's the information we use. Yes? Oh, AIHW did it. I beg your pardon. Yeah, so AIHW allocated that information, that data to those different conditions, and then they allocate some of the evidence from PBS and from MBS. So for some things, you can figure it out from codes. For other things, they're allocating proportionally to different diseases. So this is part of the work that the ABS does on the burden of disease, working out spending on different diseases. Now, we've excluded public health spending because that's prevention, which is not relevant here. We're excluding research and we're excluding capital expenditure because we do include capital depreciation. All right, so this is from the disease expenditure database at AIHW. Okay, so multi-factor productivity growth in healthcare using this approach. So basically, we are saying it is the cost of treating the disease, so the total amount spent on the disease in a year divided by the prevalence. So the cost in 2012 divided by the cost in 2018 plus your utility from the change in outcomes that you had in 2018 relative to 2012. So essentially, how much are you willing to pay for the extra health that you got in 2018 relative to 2012? So for those of you that are familiar with the healthcare work in this space, this is just exactly the inverse of the PASH reservation index constructed by Dunn, Hall, and Dowda, looking at, well, what happens to indices over this period of time. It's a good idea, for those of you that are nerds, it's a good idea to use a PASH index when you're thinking about these things, because some of these improvements in health have been so astronomical that you end up with some very silly things if you use a Lesper's index. You get negative prices and all sorts of complications. So PASH index, good. And this is what's termed a cost of living index. How does this differ from some of the other approaches? The other approach, whose name I've now forgotten. Oh, you've forgotten too.
There were many names.
All right. Basically, the other approach is to sort of look at the price of getting a certain level of health care in the new period and seeing how much less it's going to cost you in the new period. It's not very helpful for health, because often in health, what we want to consume is constrained by the technological production possibility frontier, right? If I at a certain point in time am diagnosed with cancer and I double what I spend on cancer treatment, I'm not going to get double the outcomes. There's a treatment, I can either afford it or I can't, but there are not necessarily additional treatments currently available for my particular condition. So this approach allows the impact on valuation to be larger, because it just says, well, forget how much you'd be willing to pay for it in 2012, forget what it would have cost in what 2012's health would have cost today. The question is, how much happier are you from the health care that you do receive in 2018? All right, and so I have not subtracted a 1 there, because in this form, it's the inverse of the PASH reservation index. So for example, if this was 1.03, that would mean that we had 3% productivity growth, and it would mean that the quality adjusted price of healthcare had fallen by 3% over that period, okay? Cool. All right, so what are the C's? The C's, as I said, are total real healthcare spending over the prevalence of the disease. So basically, again, because we're taking the aggregate approach, we in some sense don't have to answer some of those questions. We're saying, well, everyone who has the disease, what are we spending on them this year? So what is the cost of treating the people who have the disease this year per case? And then what is this increase in our valuation of the outcomes? Well, at its base, it's pretty simple. It's how much is a QALY worth times what QALYs do you get after healthcare treatment in 2018? And then we subtract that. That's relative to what you got in 2012. How much is a QALY worth? How much did you get? How many QALYs did you get from healthcare treatment in 2018? We just need to make one adjustment, which is that if you are treated today and you survive, you then cost more down the track because you are going to have further healthcare in the future. So we do need to make an adjustment for the fact that there are additional costs down the track. So we make an adjustment for the fact that you will cost more to the healthcare sector in the future because you've received this healthcare in 2018, and same adjustment in 2012. All right, so very simple. It's just saying, what extra qualities did I get? How much are they worth to me? And I need to make an adjustment for the fact that if I heal this person, they're going to cost the health system more down the track. Yep.
Okay. So the value of the quality is a value to me, the patient, and then you account for the future cost of the healthcare system. But maybe then you're missing the additional tax revenue you might get from the person because they live longer. So if you're going to account for the fact they impose costs on the system, then you'd also want to account for that, because I don't care about that when I value a quality in my head.
Yeah, that's a very good point. I think if you looked at the data and a very large share of the people who were affected by these diseases were under the retirement age, you would definitely want to take that into account. That's a good point.
Yeah, and I think it will vary a lot by disease. Right?
Yeah.
And the other thought is the total real healthcare spending is deflated with something like aggregate CPI, I imagine, or
No, Lawson?
It's healthcare specific price deflators. They're mostly tracking input costs in the healthcare system.
Okay, perfect.
Sort of the ideal.
Cool. Yeah,
I'd
great.
like to say as well, in response to your first question, so Catherine will get to this in a bit, but part of the assumptions we make is that sorry, now I'm on the record. In the future, we make an assumption that you'll revert back to sort of population average levels of health. And part of that is that you will consume more healthcare in the future. And so your returning to the population average level of health is conditional on you having healthcare in the future. And so that's why we take out the healthcare spending in the future and we don't treat other things in the same way. It's because you wouldn't be able to obtain that QALY score if there wasn't this future cost incurred. That's the logic.
Yes, but if the treatment is provided and you do incur the cost, then there should be extra tax revenue, right?
There will be extra tax revenue, but there'll be all sorts of other things in your life as well that are valuable. We're just focusing on the healthcare component, and we didn't think it's reasonable to focus on just the benefits you'll get from future healthcare without accounting for the costs you'll get from future healthcare as well. But if you want to look at economic outcomes, there's millions of things other than tax revenues, whether you're focusing on benefits to the society as a whole or benefits to you personally. There's going to be a lot of stuff. And so I think you have to draw the line somewhere.
Yeah.
It is really tricky. This one does my head in, I'll be honest. And so we've definitely gone a few rounds on this one. All the hard questions are for my co-author, Lawson Ashburner. So okay. So yeah, it is a challenging one. We do need to think about, well, if someone does recover, what then? But it is a little bit tricky to figure out what should be in the formula, and I don't think there's an obvious one right way. Okay, so what is the number of QALYs that you get from treatment? What we have the survival rate. So the survival rate, again, is looking at the mortality in any given year from that. So again, you want to be thinking in the aggregate about all of this. So this is survival rate for everyone who has leukemia this year, for example. And then a measure of the quality of life that somebody experiences who currently has the disease. And then if they recover, their health-adjusted life expectancy for somebody who has their age from that point onward. So the way to think of this formula is it's as if everybody has every disease for just 1 year. I have it for 1 year. I might survive, I might not. if I survive, I have lower QALYs this year, and then we assume that I'm kind of the average amount of healthy after that. Now, obviously, people have diseases for different lengths of time, as you pointed out, but because we're doing this in the aggregate, that kind of washes out. It's sort of the same if one person has it for 5 years and 5 people have it for less time, it comes out in the wash. So that part is okay. Everybody all right so far? Okay. And then the big assumption here is it assumes that if somebody does recover from the disease, their health reverts to the population average. So that's a pretty standard assumption in the literature, but it is a little bit optimistic. If you've had a serious health outcome, chances are your health will be poorer after that. But that's the assumption in the literature. And so we discount that health-adjusted life expectancy. We discount these costs and this utility at 7% in real terms, which is the recommended discount rate from the Office of Impact Analysis. Yes? What it means is that, so hang on. The question was, what does that mean? What it means is all of this, think of all this as being in dollar terms. So if a QALY is worth, we're going to assume $110,000 to you, which is a sort of, we found a few different estimates out there, and that was the middle one. If a QALY is worth $110,000 for you, but you'll get it next year, you get that divided by 1.07. So in terms of what it's worth today to treat you, the benefit that society is getting from that, it's not just the full sum of QALYs you'll get for the rest of your life. We discount them. It's probably a way of balancing against this very rosy first assumption. It's like, well, maybe you won't be that healthy. Maybe we're not going to get all these amazing benefits that yes, Erwin.
Seems like very large.
Hold
Hang on one sec. Sorry, I'm messing with the protocol.
7% real seems like a very large number. Just
does.
how did they come up with that?
They're a very
Maybe
risk-averse
off
group. They've dealt with a lot of politicians who inflate the cost of the values from benefits from infrastructure projects. That's where it comes from. Thank you. Very conservative. Okay. So quality of life. So this is the cute part. This was Lawson's idea. How are we going to get that quality of life estimate? So unfortunately, the National Health Survey does not include a quality of life questionnaire that has been mapped to some sort of health utility. But HILDA has some of those same questions as the National Health Survey, and it does have a quality of life questionnaire. So what we do is we use HILDA to figure out how your answers to those questions about pain, about stress, about your self-reported health, how they relate to quality of life. We get a relatively good R-squared, and so we can use that to look at the responses of someone on the National Health Survey and predict what would be the measure of their quality of life. And so we do this using stratified propensity score matching. We match each survey respondent who has the disease with a similar respondent, and so that gives us the loss of utility basically from having this disease. So here are estimates in different years for these treatments. So the way to read this is in 2011, you lose about 10% of the value, the QALY from that year if you have cancer. And that one comes down. It doesn't look as rosy. The QALYs, the cost of these in terms of YLD is not coming down as much in the others. Okay, and then that gives us the productivity in each disease and age group, and then we weight them by their population shares. What did we find? I'm glad you asked. So we found a very high productivity growth rate in cancers, a negative productivity growth rate in cardiovascular disease, a positive productivity rate in blood, endocrine, and kidney diseases, for an average of 3% per year. Remember, the multi-factor productivity in the market sector over this period was 0.7% per year. So 3% is a very big number. This suggests that this sector was very productive over this period. Yeah, you don't care. That's fine. So the question then becomes, well, what is driving this productivity? And so, interestingly enough, very little improvement in the cost of treating a disease, no improvement in quality of life with the disease, but very big improvements in the survival rate with the disease. So very striking results. So we did this by holding different bits constant. So it's a really interesting result. It's kind of surprising that we've had so little improvement in terms of your quality of life with a disease, but really good outcomes on survival. So that life expectancy that we saw at the beginning, a lot of it is attributable to the health sector. Now, first thing is productivity looks really different in these different diseases. As I mentioned, I think in cardiovascular disease, that's because we've gotten better at preventing it, and there haven't been big improvements in treatment over this recent period. But here's the bad news. This productivity growth has probably been driven by dissemination of new treatments from overseas. Why am I guessing that? Because this productivity difference is so different across these different diseases, right? They're being treated in the same hospitals, but we're seeing totally different productivity. That's probably because in some cancers we've developed new treatments, and in cardiovascular there haven't been as many innovations in this period. So that tells us that what we're actually measuring here is not so much the productivity, just the productivity of our healthcare. A lot of this is probably the productivity, the improvements in quality of our inputs. And so that points to the need to get not just better estimates of productivity, but also better estimates of input quality. And that's it. I'll leave that there. I just want to say there is more really interesting work in this space, but I should leave it there.
Thank you very much, Catherine. Questions, comments, complaints? Professor Dewart.
Thank you. You mentioned briefly that capital cost was depreciation. Is there an opportunity cost of capital in there?
No, I don't think there is.
So that's a problem.
Okay.
And if you've got a 7% real rate of return on one part and then nothing on the other part, little asymmetry.
Yep. Okay.
And then land. I mean, hospitals sit on their valuable land. And so that should be in there as well.
Okie doke.
Thank you.
No, very good point. We'll go in, work on that.
I was struck by the difference between coronary heart disease and cancers, and I saw a graph that we produced some time ago, which kind of corroborates what you've said, and the numbers are truly striking. The coronary heart disease deaths per 100,000 people have gone down by a factor of 8 since 1974. A factor of 8. And so the pool of people who are getting is completely different.
Very
so
different.
Absolutely. So whereas we haven't made anything like that progress on other things, we've kept all these middle-aged men who overeat alive.
Yeah, statins work, it turns out.
Yeah, which turns out probably quite good for productivity and probably even quite good for restaurants. But it is, I mean, I think you've got very strong reason for believing that it's just a totally different pool of people at the beginning and the end of this period.
Yeah, so I do take heart. I'm not so worried that we're getting that negative estimate of productivity there. I think it comes from that assumption that that we're ignoring, we're taking as exogenous who gets the disease. Thank you, David. That's really helpful. We'll try and include that graph if we do another piece of work with this.
Thank you. Very interesting presentation. Super important topic. I've two questions, one comment. My first question is, maybe I missed out, but where does your assumption or evidence come in on the marginal effect of care on the quality of life? I mean, you cannot, obviously you don't want to attribute all changes in the quality of life to healthcare, right? And so it just escaped me, but this seems a very important step to get through. So
what we're doing is what we're doing is we're basically comparing the quality of life of people who don't have the disease with people who do have the disease, kind of with a propensity score, we're matching them. And so essentially we're looking at, so if most men who are 70 years old are depressed, we look at, what is your level of depression compared to the average, if you will.
But I meant the marginal effect of healthcare, right?
Oh.
Because there are many reasons why your quality of life, your life expectancy may increase, lifestyle and all. But how do you get at the effects of healthcare? Because that's what you want to measure for the quality adjustment, right?
Yeah. Do you want to take that one, or do you want me to?
This is why we do the disease-based measure, basically. So it's very hard to control for all of those other changes. The only way we can really do it is to assume that everything else that happens in the world affects the prevalence of the disease, it's not quite whether you get the disease, that's incidence, but sort of like that. And then once you have the disease, changes in your quality of life are attributed to healthcare. But that's why we make these strong assumptions about exogenous onset of the disease, because that's sort of the only way that we can control for that. There is one other approach that's been used in the literature that's much more complicated, and I don't think we'd be able to do with the data in Australia, but it's just a hard identification problem, I think.
Okay. Yeah, I just mentioned it because I think it's a key point that needs to be underlined. My second question was a very small one. When you value the quality of life, so the VQ, I mean, you use that is value in 2018 prices.
Yeah.
That's why you're saying it's a patch index inverted. Yes. I mean, conceivably one could use a Las Pairs and then take an average, right, and get to a Fisher index. I mean, so because the numbers are big, that may actually play out.
Okay, thank you. We'll give that some thought. That's
and
helpful.
my comment, is just the quality adjustment of healthcare is important whether it's non-market or market. It's not a non-market issue only because you need to do just the same thing for healthcare that is provided by private hospitals.
Correct. Yeah, no, thank you. Very good point.
Yeah, hi. Shameless plug. The ABS is giving a presentation tomorrow afternoon, which touches on a lot of this stuff.
Excellent.
Around what we're thinking about doing, or what we aspire to do, I guess, in terms of productivity measurement over the next little while. And a lot of it does kind of center on non-market measurement. But I guess the question that I've got is, I guess, like, productivity to me is a supply side concept. It's inputs and outputs, and you kind of think of the typical sort of factory that you might kind of come across in a microeconomics textbook, and so they employ labor and capital to basically maximize profits. But the public health system doesn't operate the same way. It kind of invests in labor in a different kind of way. It invests in fixed capital in a different kind of way. And I guess by the time you kind of, when we start thinking about survival rates and quality adjusted life years, we're a long way from the factory floor. And I guess I'm kind of just struggling to kind of like, does this connect to the productivity kind of agenda, for want of a better term, or is this more around sort of like improving people's lives through a well-being channel or a welfare channel?
Yeah, no, that's an excellent question. It absolutely relates to the productivity question. So we've done a lot of work on the diffusion of innovation. So Australia, as a small open economy, mostly takes its innovation from overseas. A big measure of productivity for us is how quickly we fold that innovation into our firms, and it's a struggle at the moment. We're doing that quite slowly in the market sector. What we were able to show here is actually this innovation from overseas is being folded into practice in Australian hospitals, and that is making a very significant difference to outcomes. So no, I think it's the same conversation about productivity. Is there a question over here?
Over here.
Oh,
Hi, Richard Hayes.
Hi, sorry.
Sorry, down here. ONS UK. I was the methods advisor on the UK's public service productivity review over the last couple of years. And I think, well, I know I'm giving a talk on that tomorrow, which I think will complement what you presented here today. I think we take a number of different assumptions, primarily because our data sources are different. So we don't take a disease-based Cutler approach. We use comprehensive health event statistics to look at individual treatments given the costs which are related to them. But a lot of our work over the last couple of years has been thinking about the impact of prevention and the high to low cost shifts, which are key aspects of productivity that you were mentioning. But I just wanted to confirm that the data sources you were using were more about individual level micro data about their health narrative rather than hospital-based event statistics. Because I was trying to work out why we'd made so many different assumptions across so many parts of what you've just shown.
We're using some aggregate data and some individual level data, but I think the big difference is we're looking at productivity conditional on getting a disease. And so that leaves aside, unfortunately, that whole incredibly important area, which is prevention. And obviously that is vital for productivity and is not addressed here. Yeah, no, it's a great point. Thank you.
Thanks. Very interesting. One thing you haven't touched on, so basically what you've done is the change in quality adjusted life years between time t and t plus x for disease I. I just wonder how much of that is due to earlier diagnosis, do you know? Do you have any insight into that? Because the earlier something is diagnosed, the more likely you are to have a more positive outcome.
So the big thing that people worry about here is cancer screening, and that was suggested to us by many people. We got lucky here, basically. If you look at how Australia's cancer screening programs have evolved over the last 20 years, it just so happened that the period of time we were studying, which is we chose because it was the period that we had data on, and it was prior to COVID, because COVID just sort of messes with everything. It just so happened there wasn't any major expanse in cancer screening. Yeah, but you know, had it been 5 years earlier, then it would have been a problem.
This is getting very dark.
So Catherine, I understand the reason the Productivity Commission undertook this was to try and help out the ABS in measuring more the non-market sector, particularly healthcare. How has that been received? Is the ABS going to move on this and try and change the way healthcare is measured in Australia?
I guess we'll find out tomorrow from Jason's talk. Look, I think it should be a collaborative effort, right? It should be the ABS, it should be AIHW, it should be us when we can. But we'd like to remind you that we're not the experts. This is a proof of concept, nothing more.
I was just going to say, I mean, it seems to me, answering the question, given that we are spending as a society a rising share of our income on healthcare, it's above 10% 10% now, and it's going up faster than other parts of the system. It is a very important question. Are we spending this money? To the extent that we can tell, is this money buying us improved outcomes? Now, this is only a third of spending, but that's better than nothing. And I mean, yes, it'd be lovely. It will, to answer your question, it'll require more resources, and we have to make judgments, just like Vipin has to make judgments about what things you do and what things you don't do. But I do think whether it's a pilot or not, it's a big deal to find that this third of the healthcare system is generating, as best you can tell, 3% productivity growth per annum. That's a big deal. And it suggests that we're not just I mean, I'm sure there is parts of the system that are wasting money, but there is a sense in which a big part of the system is doing something that's well worth paying for.
Thank you, David. Really appreciate it.
Any other questions? Alicia.
Thanks again. I've been in a few of like panels, and many of our colleagues that are private sector economists are constantly saying, looking at these numbers going, oh, look at the non-market sector. And I keep saying, we don't know how to measure this. So, and I think that this is so important that we start to tell people that it isn't that the non-market sector is non-productive. It's just that we don't know how to measure the outputs and the inputs, and this is how, and we don't know prices. And so I don't know how we go about this, but it is super important that we do, because it is a continuous thing that you have to push back. Because I'm not really sure what the agenda is, because I don't know, privatize the healthcare system. I mean, I don't know what the agenda is, but basically we need to be able to measure things correctly. And this is one of the most important sectors in the economy. And so, yeah, thank you.
Well, perhaps I can ask about the generalisability of this. Has the Productivity Commission been looking at applying this methodology to any other part of the non-market sector?
We haven't, but we would like to continue to look at some other parts of the non-market sector. I think aged care would be the obvious next one, because there are going to be some good measures of satisfaction with aged care coming gradually, and also there's some pretty good data on falls and restraints and other types of outcomes in aged care. But I suspect that the productivity is hugely variable in the non-market space. And so it is going to be fascinating as we uncover those different outcomes.
Great. Richard?
I'll not preempt my talk too much, but we published stats back to 1997 for health, education, criminal justice, adult social care, children's social care. We'll be publishing police and immigration from March. So I think the case that we can actually roll these methods out quite easily across most of the public services, apart from defence, which I'll explain tomorrow, is pretty much made.
That's very exciting. Thank you, Richard. We're all looking forward to that.
Would anyone speaking at the same time in a parallel session to Richard like to put in a plug for their talk? Okay, well, I think Catherine's talk, and thanks to Lawson as well for contributing there. It's a great tag team effort. I think that's given us a lot of food for thought. And as we go to a little bit of an early afternoon tea, please make sure you eat lots of fruit or whatever other healthy options there are out there. Look after yourselves, and please join me in thanking Catherine and Lawson.